Dr. Areeba, are you ready?
Yes, sir.
So I'll do a brief introduction, and then you can start your presentation. So I welcome you all to yet another session of the Residence Corner module. These sessions are arranged by the Department of Neurosurgery at Liaquat National Hospital, and the idea behind these session is to build 3D neuroanatomy, which is very important while doing any surgeries. It gives me great pleasure to introduce our expert panelist today. He has had a great influence on my training as chief. Dr. Areeba, can you mute yourself, please? There's a lot of echo. So it gives me great pleasure to introduce our expert panelist today. He has had great influence on my training as a chief resident. Dr. Mohammed Riaz is currently working as a professor, University of Colorado. He has done skull-based fellowship from Louisiana State University and minimally invasive spine fellowship from Georgetown. He was recently nominated as a top neurological surgeon representing Denver, Colorado by a local website, there. I welcome Dr. Riaz. Thank you, sir, for joining us.
Good morning, everyone. Thank you, Saad. Pleasure is mine.
So the topic of our presentation today is posterior fossa arteries. We'll try to cover as much as possible, but for today we have superior cerebral artery that Dr. Areeba will cover. Dr. Areeba is a fourth-year neurosurgery resident at Liaquat National Hospital. Dr. Areeba, can you start your presentation?
Yes, sir.
So somebody sitting there has to mute themselves because there's a lot of echo. Please ask them to mute themselves.
Assalamu alaikum.
Well, Salam, it's better now, Areeba. You can start.
Okay, sir. Assalamu alaikum. Good morning, everyone. The topic of today's presentation is posterior fossa artery, roton session. We will be covering superior cerebellar artery, ICA and PICA in this session. So this is first part of a three-part series. So let's start with the presentation. Okay, so we will be discussing superior cerebellar artery, ICA and PICA in the next upcoming sessions. So the basic and the most important way of discussing the posterior fossa arteries is to divide them into complexes. So we have three basic complexes: the upper complex, the middle complex, and the lower complex. Each complex has its own artery, its own surface to supply of the cerebellum, its own fissure, its own cerebellar peduncle, its own associated cranial nerves, and part of the brainstem. So starting from the upper complex, the artery of the upper complex is superior cerebellar artery, which we are going to discuss today. It is associated with midbrain of the brainstem. The arteries, the cranial nerves that are going to be associated with it will be third, fourth, and fifth. The fissure that is going to run in it is cerebello-mesencephalic fissure. Since we are associated with midbrain here, so it will be cerebello-mesencephalic fissure here. The peduncle associated with it will be superior cerebellar peduncle and the surface of the cerebellum, which is going to supply its tentorial surface. Similarly, the middle complex, which we will be discussing in ICA presentation, the middle complex, its main blood supply is ICA. The part of the brainstem that it is associated with its pons. Cranial nerves associated with it are 6th, 7th, and 8th. The middle cerebral peduncle and cerebellopontine fissure. Now we are talking about cerebellopontine fissure because it's associated with pons. Here it was midbrain, so we had cerebellomesencephalic fissure. And the surface of the brain, cerebellum, which is going to supply is petrosal surface. The lower complex, its own artery is pica. It will be associated with medulla. The arteries, the cranial nerve that will be associated with it will be 9th, 10th, 11th, and 12th, the lower complex. Cerebellomedullary fissure will be the place where it will be running. Inferior cerebellar peduncle will be in close approximation, and the surface of the cerebellum, which is going to supply is suboccipital surface. If you remember this diagram, it will be very easy to understand the posterior fossa arteries. So today we will be discussing the SCA and of course the upper complex. So we will be discussing about midbrain. We will be talking about cerebellomesencephalic fissure, the association with superior cerebellar peduncle, and we will be seeing third, fourth, and fifth cranial nerve here. So starting from the superior cerebellar artery, as we know previously that we have two vertebral arteries that join together to form a basilar artery that runs on the dorsal surface of the midbrain brainstem, and then it's going to divide into two PCAs. And here it will be giving branches like superior cerebellar artery, ICA and PACA, which will be making upper complex, middle complex, and lower complex. So the SCA is intimately related to the cerebellomesencephalic fissure, the superior half of the fourth ventricle roof, the superior cerebellar peduncle, and the tentorial surface. The SCA arises in front of the midbrain, usually from the basilar artery, here, near the apex, and passes below the oculomotor nerve, as we can see here, but may infrequently arise from the proximal PCA and pass above the oculomotor nerve. And that usually occurs when it is associated with fetal circulation. Its proximal portion courses medial to the free edge of the tentorium cerebelli, and its distal part passes below the tentorium, making it the most rostral of the infratentorial arteries, as it makes sense because it's a part of the upper complex. It usually arises as a single trunk, but may also arise as a double or duplicate trunk, as we will see further. The SCA is arising as a single trunk bifurcate into a rostral and a caudal trunk. So as we can see here, this is the superior cerebellar artery. Now we are seeing a lateral diagram. We can see after its origin, it divides into two branches or two trunks, a rostral trunk and a caudal trunk. And as we can see here, it will be the most rostral of the infratentorial arteries. The SCA gives off perforating branches to the brainstem and cerebellar peduncles. Pre-cerebellar branches arises within the cerebellomesencephalic fissure. We will be discussing these later. SCA frequently has point of contact with the oculomotor, trochlear, and trigeminal nerve. As we have discussed previously, there are three nerves that are closely associated with the upper complex, or the SCA are the third, fourth, and fifth nerve. So now we can see this in detail. As we can see here, the upper complex, the SCA, after its origin from the basilar artery, here it's divided into two components, two trunks, a rostral trunk and a caudal trunk. And it is associated with third cranial nerve and fourth cranial nerve and part of the fifth cranial nerve. Now, for ease of understanding, it's basically divided into four segments. The anterior pontomesencephalic segment, which is known as the S1. The lateral pontomesencephalic segment, which is known as the S2. Third, S3 is the cerebellomesencephalic segment, and S4 is the cortical segment. So, as the name implies, it's easy to understand that anterior pontomesencephalic segment will be running anteriorly in the pontomesencephalic fissure. The lateral pontomesencephalic will be running laterally on the surface of the pons and the midbrain. And the cerebellomesencephalic will be running in the cerebellomesencephalic fissure, as we discussed previously, that the upper complex is associated with superior cerebellomesencephalic fissure. And the cortical branches will be supplying the cortex. So let's move on further and describe each one of them in detail. So the S1 segment, or the anterior pontomesencephalic segment, is located between the dorsum ocelli and the upper brainstem. This one, which is highlighted in red. It begins at the origin of the SCA, and we know that SCA originates from the basilar artery and extends below the oculomotor nerve, as seen here, to the anterolateral margin of the brainstem. Its lateral part, this part, is medial to the anterior half of the free tentorial edge. This is the tentorium. So as you can see, its lateral part is medial to the anterior half of the free tentorial edge. This is S1, or anterior pontomesencephalic segment. And it's associated with third cranial nerve. Now the second part, or S2, is lateral pontomesencephalic segment. This begins at the anterolateral margin of the brainstem and frequently dips caudally onto the lateral side of the upper pons. So if we will have a lateral diagram, so the S2 segment will have a caudal trunk, or sometimes it dips caudally up till the part of the pons. Its caudal loop projects towards and often reaches the root entry zone of the trigeminal nerve at the midpontine level. So a better picture to show this will be this. So sometime the lower part of the rostral part, caudal part of the S2 will dip as much caudally as the dorsal root entry zone of the fifth cranial nerve. The trochlear nerve passes above the mid portion of this segment, as we can see here. This is the trochlear nerve, and here this is the trochlear nerve. The anterior part of this segment is often visible above the tentorial edge, but the caudal loop usually carries it below the tentorium. This segment terminates at the anterior margin of the cerebellomesencephalic fissure, from where S3 segment arises, and the basal vein and the PCA courses above and parallel to this SCA. Now, as we have seen previously, that anterior, the S1 or the anterior pontomesencephalic segment is associated with cranial nerve 3. The S2 or the lateral pontomesencephalic segment is associated with cranial nerve 4. The S3 or the third segment is cerebellomesencephalic segment. As the name suggests, it's going to run in the cerebellomesencephalic fissure. So this segment courses within the cerebellomesencephalic fissure, which is shown here after retracting the cerebellum. The SCA branches enter the shallowest part of the fissure, located above the trigeminal nerve entry zone, and again courses medial to the tentorial edge, which is branches intertwine with the trochlear nerve through a series of hairpin-like loops. The SCA loops deeply into the fissure and passes upward to reach the anterior edge of the tentorial surface. So S1, which is anterior pontomesencephalic, associated with third nerve. S2, lateral pontomesencephalic, associated with trochlear nerve. And cerebellomesencephalic fissure runs in the cerebellomesencephalic segment runs into cerebellomesencephalic fissure. Now the fourth segment will be the cortical segment, S4, which is going to supply the cortex. As we have discussed previously, that the upper complex is associated with the tentorial surface of the cerebellum. That is the surface of the cerebellum that is lying just beneath the tentorium. So if here, as you have seen, that we have the author has removed the tentorium, and the surface of the cerebellum that is visible now is the tentorial surface. And the branches that are going to supply it are the S4. So cortical segment or S4 includes segment branches distal to the cerebellomesencephalic fissure that passes under the tentorial edge and are distributed to the tentorial surface. And if a marginal branch is present to the upper part of the petrosal surface as well. As we have discussed previously, that the petrosal surface of the cerebellum is supplied by the middle complex, and the upper complex supplies the tentorial surface. But sometimes an artery called the marginal artery is present, which supplies the petrosal surface of the cerebellum as well. We will be discussing it shortly. So after discussion of the all four segments of the SCA, let's move on to some dissections before we go on to bifurcations. So as we can see here, we can see that this in the diagram A, that basilar artery gave rise to SCA. The first part of the SCA that is running anteriorly is the S1, and oculomotor nerve is seen to be passing above it. S2 or the lateral pontomesencephalic segment runs laterally. We can see cranial nerve 4 associated with it here, this one. S3 runs in the cerebellomesencephalic fissure, and S4 supplies the cortical surface. Similar diagram laterally. Here we can appreciate the thing that we discussed here in S3, that is the PCA and the superficial petrosal vein. They are parallel to it. So we can see that the basal vein and the PCA courses above and parallel to this SCA, the lateral pontomesencephalic. We can see here that this is PCA and it is parallel to this S2 segment. Again, a proper diagram in segment D, we can see that the cerebellum is retracted and we can see the cerebellomesencephalic fissure properly, and we can see that hairpin-like loops that S3 or the cerebellomesencephalic segment of the SCA takes. Now, again, a better diagram showing the upper complex. We can see the relationship of the third nerve, the fourth nerve, and the fifth nerve and how they are associated with the superior cerebellar artery. Now moving on to the next part of the SCA, that is bifurcation. We know that all the SCAs that arise as a single vessel bifurcate into two major trunks, one rostral and one caudal, as we have discussed previously. This bifurcation occurs most commonly near the point of maximal caudal descent of the artery on the lateral side of the brainstem. The rostral trunk terminates by supplying the vermis and a variable portion of the adjacent hemisphere. The caudal trunk, on the other hand, supplies the hemisphere surface lateral to the area supplied by the rostral trunk. So the rostral trunk or the upper trunk is going to supply the medial surfaces or the vermis and a variable part of adjacent hemisphere. And the caudal trunk is going to supply the hemisphere surface lateral to the area supplied by the caudal trunk. So a good diagram here, we can see the two trunks, the two bifurcations of the SCA. We have a rostral trunk and we have a caudal trunk. And we can see how they are closely associated with cranial nerve 4 because they are part of S2. They mostly arise in S2. Again, in a better diagram, we can see a common region of superior cerebellar artery dividing into a rostral trunk and a caudal trunk. We can see that how it is parallel to the basal vein. Now, we discussed the segments and the bifurcation of SCA. Now, let's talk about the branches of the SCA. So, there are many branches that arise from the superior cerebellar artery, starting with the perforating arteries. Perforating arteries are basically divided into direct type and circumflex type. So, the direct type pursues a straight course to enter the brainstem, and the circumflex type basically winds around the brainstem before terminating in it. The circumflex types are basically further subdivided into short and long time, depending on the 90-degree turns they are going to take, how much distance does it take to enter the brainstem. The most common type of perforating artery arising from the main trunk is a long circumflex type, but it also gives rise to direct and short circumflex branches. Other type of branches that arise from the SCA are the pre-cerebellar arteries. Now, we have discussed this previously that pre-cerebellar branches basically are the branches that arise in the cerebellomesencephalic fissure or basically the S3 segment. So the pre-cerebellar arteries arise from the trunks and cortical branches within the cerebellomesencephalic fissure, the S3 segment of the SCA. As many as 8 pre-cerebellar arteries may arise within the fissure. The pre-cerebellar arteries consist of a medial group of small branches that pass between the superior medullary velum and the central lobule, and a lateral group of larger branches that course between the superior and middle cerebellar peduncles and the wings of the central lobule. Third one is the cortical branches. The SCA usually supplies a majority of the tentorial surface, as we have seen previously, and this is part of the S4 segment of the SCA. And frequently the adjacent upper part of the petrosal surface, as we have seen previously, that upper part of the petrosal surface is usually supplied by the middle complex or ICA, but sometimes a marginal artery or a branch supplies this area as well. The cortical branches are divided into hemispheric group and Vermean group. A better picture to see this will be here. As we can see, the basilar artery, and it's going to supply the divide into superior cerebellar artery here on the both side, common region of superior cerebellar artery. Then it's divided into a rostral trunk and a caudal trunk. Now, after division, as we can see that it's going to supply the cortex, the tentorial surface of the cerebellum. Here we have two main branches. So we have branches on the lateral surface and branches of the medial surface. As we have discussed previously, that the rostral trunk supplies the medial part. The rostral trunk supplies the medial part or the vermis, and the lateral trunk, the caudal trunk supplies the lateral part. So as we can see that the cortical branches, we have a Vermean branches which supply the medial surface of the cerebellum, and we have the hemispheric branches which supply the lateral surface. Now usually we have 3 hemispheric branches: a lateral hemispheric artery, an intermediate hemispheric artery, and a medial hemispheric artery. So the hemispheric branches arises from the rostral and caudal trunk in the depth of the cerebellomesencephalic fissure, that is S3 segment. The most common pattern is 3 hemispheric branches: a lateral one, an intermediate one, and a medial one, corresponding to the third of the hemispheric surface that is supplied. So we have 3 major hemispheric arteries, which are basically cortical segments or cortical branches. The lateral hemispheric artery that is going to supply the lateral surface of the tentorial surface of the cerebellum. This whole surface is the tentorial surface of the cerebellum. We are dividing it into three halves. The lateral half is going to be supplied by the lateral hemispheric artery. The middle half is going to be supplied by the intermediate hemispheric artery. And the medial half will be supplied by the medial hemispheric artery. Each branch supplies approximately 1/3 of the tentorial surface of the hemisphere. And the medial segment is most frequently supplied from the rostral trunk, and the lateral segment is most often supplied from the caudal trunk. This is what we discussed previously as well. So these two trunks, that is the intermediate hemispheric artery and the lateral hemispheric artery, these are going to be arising from the caudal trunk. And the medial hemispheric artery and the Vermian branches, these will be arising from the rostral trunk. So as we discussed previously, that after bifurcation, the rostral trunk supplies the vermis or the medial part, and the caudal trunk supplies the lateral part or the hemisphere of the cerebellum. Moving on, we have Vermian arteries. Now, as the name suggests, Vermian arteries are going to supply the vermis. The Vermian arteries arises from the rostral trunk, as discussed previously, within the cerebellomesencephalic fissure. The rostral trunk most commonly gives rise to two Vermian arteries, and the most common pattern is one distributed to medial strip bordering the midline, and one distributed to a paramedian strip bordering the hemispheric surface. Again, similar picture, we can see a single Vermian artery arising, dividing into two, one supplying the median vermis area and the other supplying the paramedian area. Now let's talk about the marginal branch. As we discussed previously, that sometimes the superior cerebellar artery supplies the middle complex as well. Going back again to our first diagram, the one we started with, we know that the upper complex main artery is superior cerebellar artery, and the surface that is going to supply is the tentorial surface of the cerebellum. And the middle complex main artery is ICA, and it's going to supply the petrosal surface. But as we have discussed previously, that sometimes upper complex or SCA supplies the petrosal surface of the cerebellum. The artery that arises from the SCA that supplies the petrosal surface of cerebellum is known as the marginal artery. So about half of the proximal SCA trunks give rise to a marginal branch of the adjacent petrosal surface. When present, the marginal branch is the first cortical branch. It usually arises from the lateral pontomesencephalic segment, that is the S3 segment, and does not enter the S2 segment, and does not enter the cerebellomesencephalic fissure, as do the other cortical branches, but passes from its origin to the cortical surface. Its most constant supply is to the part of the petrosal surface adjoining the tentorial surface. Now, as we have briefly described and discussed the segments, the distributions, and the branches of the SCA, let's look at some good anatomical dissections. As we can see here, this is the basilar artery. It's going to give rise to the superior cerebellar artery, and it's going to divide into two complexes, two bifurcation, two trunks, a caudal trunk and a rostral trunk. It runs in the superior mesencephalic fissure before it divides on the surface of the cerebellum, that is the tentorial surface of the cerebellum, into cortical segments. Again, a similar diagram, similar picture. Basilar artery giving rise to superior cerebellar artery, a rostral trunk, and a caudal trunk, a smaller caudal trunk. A thing to appreciate here is the distribution or the sizes of the two trunks. Sometimes these two trunks are symmetrical. Sometimes one trunk is predominant and the other is a little bit shallower or narrower. Another diagram showing the association of tentorium to the SCA. As we discussed previously, after its origin from the basilar artery, the segment that is going to run anteriorly in the pontomesencephalic segment, anterior pontomesencephalic segment, is the S1. It is associated with third cranial nerve, oculomotor nerve. It runs beneath it. Sometimes when it arises from the PCA and there's a fetal circulation, it runs above the third nerve, but usually it runs below or beneath the third nerve. As we can see here, it runs laterally, and its lateral part is going to run medial to the tentorial surface. This is tentorial edge. So the lateral part of the S1 is going to run medial to the tentorium. The part that's going to run laterally then will be known as S2, or the lateral pontomesencephalic segment. The segment that is going to run here in the cerebello-mesencephalic fissure, it will be the S3. And the segment that's going to survive on the surface of the brain is S4. Again, similar diagram. Now here we can appreciate the association of the cranial nerves with the SCAs. As we can see here, this is the rostral trunk and this is the caudal trunk. We discussed previously that the third nerve is associated with the S1 segment. The fourth nerve is associated with S2 segment, or the two bifurcations. And the cranial nerve fifth is present beneath and sometimes associated with S2. Sometimes the caudal trunk of SCA loops down and touches the dorsal entry zone, root entry zone of the cranial nerve 5. And this is where symptoms of trigeminal nerve arise. Again, a similar diagram showing association of SCA, division into a rostral trunk and a caudal trunk. Here we can see the asymmetrical trunks. Rostral trunk is a thicker or a predominant trunk. We can see cranial nerve 4 associated with it and tentorium on its lateral edge. Now here a thing to appreciate is the close association of the PCA that will be present somewhere here and the basilar veins to the S2 segment of the SCA. An association of the caudal trunk to the cranial nerve 5. Similar diagram. Now in this cadaveric dissection, this patient had a caudal trunk of SCA that was touching and looping around the cranial nerve 5, causing symptoms of trigeminal neuralgia. Now, why it's important to learn the relationship of trigeminal nerve? Because the most common disease or clinical significance of the upper complex is that we see patients who have trigeminal neuralgia caused by the disturbance of the trigeminal nerve by the caudal segment of the SCA. So the trigeminal nerve arises from the lateral part of the pons and runs obliquely upward. It exits the posterior cranial fossa by passing forward beneath the tentorial attachment to enter the Meckel's cave. The SCA encircles the brainstem above the trigeminal nerve, making a shallow caudal loop on the lateral side of the pons, as we have discussed previously. About half of the SCA have a point of contact with the SCA, which, depending on the site of bifurcation, may involve the main rostral caudal or both the rostral and caudal trunks on a marginal hemispheric branches. As we have seen here, that mostly it's a caudal trunk, but sometimes it's even the rostral trunk, both trunks that are making a point of contact with the trigeminal nerve. The point of contact with SCA is usually on the superior or superior-medial aspect of the nerve. Easily seen here. Usually it's the superior or a superior-medial aspect of the nerve. Often a few fascicles of the nerve are indented or distorted by the vessel, 3 to 4 mm, but as much as 12 mm peripheral to the point of entry into the pons. So this was all about the superior cerebellar artery. I hope it's pretty clear. Next week, we will be discussing the middle complex, that is ICA, and that will be followed by the lower complex artery, that is PICA. Thank you.
Thank you, Dr. Thank you, Dr. Areeba, for for a detailed presentation. Now I would like to request Dr. Mohammed Riaz for his expert opinion, and maybe if he can share his cases. Dr. Mohammed Riaz.
Do you hear me?
Yes, sir, we can hear you.
Good morning, everyone. Thank you, Saad. Saad, thank you so much for inviting me to this fantastic lecture. And Areeba, you did a great job. And you discussed the minute detail of all the SCA and the posterior circulation arteries. Being a neurosurgeon resident, it is critical and crucial to have a thorough knowledge of posterior circulation, its relation to the cranial nerve and the main component of the posterior fossa, brainstem, like pons, medulla, and midbrain. And it's critical to have that thorough knowledge of the posterior circulation. I can. What is your pattern, Saad? Would residents participate in it, and who the participants?
So if you ask question, they can use the chat box and answer your questions. They cannot speak, but they can use the chat box. So you can share your presentation if you have one, or the cases if you have one, and you can ask them questions, and if they're not sleeping, then they will use the chat box to answer you.
So, question. Okay. Do you see my screen now?
Yeah, it's shared.
Okay, I can see big gun, Dr. Salman Sharif. So my name is Riaz. Saad already introduced me. I worked at Aga Khan University Hospital back in 2010, 11, 12, 13, 14. And 14, I was a chief resident. Saad was my junior, and we worked together. Saad and I, we had great memories, and we worked together. It was amazing time back in the days. And then I moved to USA, and I did my fellowship in minimal invasive spine surgery from Georgetown University Hospital, Washington, DC. And then I moved to Louisiana. I did my skull-based fellowship with Dr. Anil Nanda. It was a year fellowship from LSU Shreveport. And then I moved to Colorado. I did another fellowship in pediatric neurosurgery. And after my third fellowship, I was appointed as an assistant professor at University of Colorado, Denver Health. It's my third year being an attending neurosurgeon, and pretty busy service here at University of Colorado. So I do both peds and adult. So my 70% practice is pediatric neurosurgery, and 30% when I'm on call, goes to adult. I do both adult spine and brain as well. So I don't want to go to the detail of anatomy in the posterior circulation, posterior fossa circulation. Areeba already discussed pretty much extensively, and there is no point for me to jump in there and further highlight it. So I will jump straight to my cases. This is an 11-year-old male who presented to ED with vomiting, ataxia, headache, double vision, and walking difficulty. While he was in the ED, MRI brain was, we don't do CT scan in peds population because of radiation exposure. So MRI brain was done. That this is the pre-contrast and post-contrast showing a huge posterior fossa mass, obliterating fourth ventricle at some extent, but it's not, it's open at this point. This kid was awake and alert with GCS 15. There was no sign of hydrocephalus. Sagittal section of the same MRI showing the mass in the posterior fossa. This kid was kept in the ICU, and further workup was done. MRI spine was done because the MRI feature was suggestive of medulloblastoma. MRI spine was clear, and then he was kept on steroid and planned for surgery. So we did midline suboccipital craniectomy, and lesion was resected. Frozen was suggestive of medulloblastoma, and surgery was uneventful. There was no problem, no complication. As Areeba explained already, we encounter all those vessels, the pica, ica, those branches going to the surface of the cerebellum. But you got to be very careful when you are dealing such lesions, and you got to pay particular attention not to violate any of the branch of the major artery to avoid complication. Post-op, this kid did very well. Unfortunately, frozen was medulloblastoma, but later on I'm going to explain this to you. The permanent pathology was medulloblastoma as well. So the post-op images pretty much grass-tool resection of the lesion, no residual, and sagittal images, post-op images, no residual tumor. And the permanent pathology came back with medulloblastoma. Unfortunate kid, but this is what it is. He went to radiation, and now he's still having his radiation. So my second patient is a 26-year-old female who presented to Denver Health Medical Emergency Department with headache, vomiting, imbalance gait, and double vision. CT scan was done in the ED, which showed this right cerebellar lesion going into the CP angle with massive hydrocephalus. Clinically, she was awake and alert with GCS 15, so we didn't feel like to put an EVD in the ED. She was kept in the surgical intensive care unit and was kept on high-dose Dicarron, and surgery was planned. MRI was done while she was in the unit, and it showed posterior fossa huge lesion. Post and pre and post contrast suggestive of meningioma. She was planned again for surgery, and this patient we placed an EVD before positioning her while she was supine with using a handheld drill. Right frontal EVD was placed and she was prone with stealth guided paramedian suboccipital cranectomy was done, and a frozen was suggestive of meningioma. Post-op images, I did this case recently, like a week ago, and post-op pre-contrast and post-contrast cross total resection. She did very well. EVD was weaned and she went home. Now the biopsy came back, WHO grade 2 meningioma. I mean, again, she will have radiation, but she did very well. She will have that surveillance with MRI. Nothing very serious. Third patient, so I just divided my cases like peds and then the sort of middle age and older age. I don't have a vascular case because regarding the posterior circulation, particularly the superior cerebellar artery, when I was a resident, I had only one case with SCA aneurysm, and when I was a fellow, I had only one case. When being an attending, I haven't encountered a single case. It's so rare, and when there is an aneurysm, usually our endovascular colleague, they usually deal with that. So I don't have a vascular case. So this is a 70-year-old male who presented from a VA hospital with headache and dysarthria. CT scan was done that showed this lesion. So he was shifted from a VA hospital. So MRI was done and it was in the CD. So I don't have access to those images, particularly the MRI. But CT scan was done in our department in our ED. So that's the pre-op images. Ring enhancing lesion in the fourth ventricle, not in the fourth posterior fossa with mass effect. Sagittal images, and we did further workup because of the lesion was suggestive of mets or abscess, and it came that he had left lung lesion. He was planned for midline suboccipital cranectomy, and the surgery was uneventful. He did very well, but again, the biopsy came back metastatic small cell carcinoma. That is very unfortunate. Any question from the participant?
Thank you, Dr. Riaz, for your presentation. If there are any questions for Dr. Riaz, you can all use the chat box. Thank you, Dr. Riaz, for these excellent cases with such excellent outcome. So have you encountered any case of trigeminal neuralgia during your...
Well, I encountered a ton of cases when I was a fellow, a skull-based fellow with Dr. Nanda. He did a lot of trigeminal neuralgias, and I have a paper on that too. But being I came to being an attending, I haven't, because we referred all vascular cases to our vascular colleague. So it's a specialty program, vascular neurosurgery. They usually deal with that.
Okay. So since I don't think there are any questions, and I think you guys did an excellent job with your explanation. If there's no other thing, I think we'd like to conclude the session. Dr. Riaz,
Thanks, Saad. Thanks.
It was a pleasure. It was a pleasure to have you, sir, and we'll keep bugging you in the future as well. Sure. And I'd like to conclude this session. Next week we'll be doing the rest of the posterior circulation. We couldn't do it in 1 week, so Dr. Areeba will be presenting the ICA and PICA next week. It was lovely to have you all. Please take care of yourself and stay safe. Thank you all.
Thanks.